Look initially from behind the patient for any obvious muscle wasting, asymmetry or scoliosis of the spine. Look from the side for normal cervical lordosis, thoracic kyphosis and lumbar lordosis.
I'm just going to feel down the back. Let me know if there's any pain.
Feel down the spinal processes. Over the sacroiliac joints. And palpate the paraspinal muscles for any obvious tenderness. Flexion and extension should be assessed.
Can you bend forward as far as you can go?
2 or 3 fingers placed over the lumbar spine will move apart and then together during flexion and then extension.
Can I get you to turn to the side again?
Lateral flexion is assessed by asking the patient to run each hand down the outside of the adjacent leg in turn.
Can you just touch your left ear to your left shoulder?
Cervical movements include lateral flexion,
And look over your left shoulder.
rotation,
And now the right shoulder. And can you put your chin on your chest?
and full flexion
And as far back as it'll go.
and extension.
That's great. Can you just cross your arms in front of you?
With the patient sitting on the couch to fix their pelvis and their arms crossed in front of them, thoracic rotation is assessed.
Okay, and if you could just lie down on the bed.
With the patient lying as flat as possible on the couch, straight leg raising is performed.
Up straight. Is that painful?
No.
Dorsiflexion of the foot may exacerbate the pain caused by nerve root entrapment or irritation such as a prolapsed intervertebral disc. A brief neurovascular examination, including the assessment of limb reflexes, dorsiflexion of the big toe, and assessment of peripheral pulses should be made. If there has been any indication of abnormality from the history, a full neurological and vascular examination, including sensation, tone and power, should also be performed. The regional examination of the musculoskeletal system that has been demonstrated here contains the core skills that will be required by a student at the time of their final exams. These video clips should be used in conjunction with guided clinical teaching. It is only through real-life clinical practice that confidence in musculoskeletal examination can be improved. It's intended that the core skills presented here will be built upon in subsequent postgraduate years and tailored to the specialty each medical student eventually chooses. With both shoulders fully exposed, look from the front,
And then can you turn to the side?
the side, and behind the patient for obvious loss of symmetry, muscle wasting or scars. The temperature over the joint line should be assessed. And then bony landmarks, joint line,
just turn around,
and surrounding muscles should be palpated for tenderness.
Can you pop your hands behind your head and your shoulders back?
Shoulder movement and function can be assessed by asking the patient to put their hands behind their head and behind their back. Internal rotation can be given a measure by how far up the back the hands can go, in this case to the mid-thoracic level.
You take your arms behind you as far as they can go. And
Full extension, flexion and abduction should be assessed.
then out to the side and back down.
Markedly reduced external rotation with the elbow flexed to 90 degrees and tucked into the patient's side is a useful diagnostic test of frozen shoulder.
Okay, I'm just going to do that to you.
Place your hand on top of the shoulder to isolate the glenohumeral movement. Passive movements should be performed while feeling for crepitus. Passive movement may be particularly helpful in abduction when assessing a patient with a painful arc, where pain may be experienced between 10 and 120 degrees.
Can I just ask you to take your arm as high out to the side as you can?
Assessment of scapular movement during full abduction should be assessed by both feeling and observing the scapula from behind the patient. Function has already been assessed by asking the patient to place their hands behind the head and behind their back. Begin with looking at the patient from the front for the normal carrying angle, from the side for any flexion deformity. The posterior aspect of the elbow is inspected for obvious scars, swellings, rashes, or signs of olecranon bursitis or rheumatoid nodules or psoriatic plaques. And again, the medial aspect should also be inspected. Temperature is assessed by comparing adjacent sites. The olecranon process, lateral and medial epicondyles should be palpated for tenderness.
I ask you to straighten your elbows out as far as they'll go.
Full extension and full flexion should be assessed actively, along with pronation and supination.
Over and back again. Just going to do that myself.
These should also be assessed passively, while holding the joint and feeling for crepitus. Here, excessive extension, i.e. hypermobility, may easily be detected. During pronation and supination, the radial head and joint line can easily be identified.
And finally, can you just put your hand to your mouth?
Function can be assessed by asking the patient's ability to perform a relevant task. It is most comfortable for the patient to have their hands positioned on a pillow. In this position, look for obvious swellings, loss of alignment, muscle wasting and scars. Try to decide if changes are symmetrical or asymmetrical. Look at the nails for psoriatic changes of pitting and onycholiasis and also nail fold vasculitis. Which joints are mainly affected? The distal interphalangeal joints, the proximal interphalangeal joints, the metacarpal phalangeal joints, or the wrists. Look at the skin for rashes or signs of long-term steroid use such as thinning or bruising. Again, look at the palms of the hands, at the finger pulp, signs of palmar erythema, scars from carpal tunnel release. Feel for peripheral pulses, muscle bulk and tendon thickening. Assess median and ulnar nerve sensation by touching gently over either the thenar and hypothenar eminences, or index and little fingers respectively. Radial nerve sensation is most reliably tested over the thumb and index finger web space. Temperature can be assessed by comparing the forearm to the wrist and metacarpophalangeal joints. Gently squeeze across the metacarpophalangeal joints while watching the patient's face. Bimanually palpate any metacarpophalangeal joints which appear tender or swollen. This should be done by having your thumbs above and the index fingers below the joint. The proximal and distal interphalangeal joints can be palpated again by using thumbs and index fingers to encircle the joint, squeezing each side gently in turn to detect for fluctuance. Both wrists should be bimanually palpated in a similar manner. You should look at both elbows closely for evidence of psoriasis and rheumatoid nodules, and feel along the ulnar border. Wrist flexion and hyperextension should be assessed both actively and passively.
Can you spread your fingers out?
Ask the patient to extend their fingers fully against gravity. If they can't, this may be due to joint disease, extensor tendon rupture, or neurological damage. You may assess this by passive movement. Extensor power and finger spread assesses radial and ulnar nerves.
Can you turn your hands over and point your thumbs up?
Abduction of the thumb assesses the median nerve.
Okay.
The patient should be asked to make a full finger tuck. If they are unable to do this, again it may be due to nerve, joint or tendon damage. This again can be assessed passively. Power grip is important functionally, as is pincer grip power.
Pinch my fingers.
Other functional tests may be made, such as picking up a small object, doing up a button, or holding a pen or cup. In patients whose history suggests a carpal tunnel syndrome, Phelan's tests can be performed. This includes forced flexion of the wrist for 60 seconds, reproducing the patient's symptoms. This may be done in one of two ways.
Okay.
With the patient lying as flat as possible, look from the end of the bed, comparing for symmetry. In a fractured neck of femur, for example, one leg may be shortened and externally rotated. Any obvious leg length discrepancy may be seen and can be checked for using a tape measure. For this, a measurement can be taken from a fixed point, such as the anterior superior iliac crest, to the medial malleolus of the ankle. both sides are compared. A difference suggests a real leg length discrepancy. Obvious flexion deformity of the hip may be seen. Obvious scars should be checked for, and the greater trochanter should be palpated for tenderness.
And is that so?
No.
Full flexion of the hip should be checked for, along with internal and external rotation, with the hip and knee flexed to 90 degrees. Both sides can be compared. Thomas's test assesses for a fixed flexion deformity of the contralateral hip. The examiner's hand is placed under the patient's back to check that lumbar lordosis is removed during full flexion of the hip. The contralateral hip should then be observed. If there is a fixed flexion deformity, this leg will be forced off the couch. Trendelenburg's test involves the patient standing alternately on each leg alone. It assesses the hip and gluteal muscle strength of the side they are standing on. In a negative test, the pelvis remains level or even rises. In a positive test, the pelvis will dip on the contralateral side. Function is assessed by asking the patient to walk. A waddling gait may be a sign of hip pain or proximal muscle weakness. Look initially from the end of the bed for loss of symmetry and loss of normal leg alignment, such as varus deformity, where distal to the knee is deviated medially, leading to a bow-legged appearance, or valgus deformity, where distal to the knee is deviated laterally, leading to a knock-kneed appearance. Look for rashes, scars, swellings, and muscle wasting, and any fixed flexion of the knee. Temperature is assessed by starting at the mid-thigh and moving down, and comparing both knees to each other. Feel around the border of the patella for tenderness and behind the knee for popliteal cysts or swellings. Assess for a knee effusion by using a patella tap. While pushing vertically down on the suprapatellar pouch, 2 or 3 fingers of the other hand attempt to bounce the patella. For smaller effusions, cross fluctuation or the bulge sign is performed by emptying the medial gutter of any fluid. When the hand is swept over the suprapatellar pouch and down the lateral gutter, the medial side may refill, producing a bulge of fluid. With the knee flexed to 90 degrees, the joint line is opened and can be palpated along with the patellar tendon insertion.
You take the knee as far as we'll go. Straighten it all the way out.
Movements of full flexion and extension are performed both actively and passively. Excessive extension is a sign of hypermobility.
I'm just going to do that myself.
Both sides should be compared. With the knee flexed to 90 degrees, the knee should be viewed from the side. A posterior sag or step back in the tibia may be suggestive of a posterior cruciate ligament damage. With the hand behind the knee and checking the hamstrings are relaxed, the thumbs are placed over the tibia and a forward pull applied. Significant movement indicates a positive draw test and suggests anterior cruciate ligament damage. The lower leg may be stabilised during this by the examiner's forearm. Medial and lateral collateral ligaments are assessed by flexing the knee to 15 degrees and alternately stressing each side of the knee. With the patient standing, popliteal swellings may be more readily seen and varus or valgus deformities may be more apparent with the patient weight bearing. Functional assessment includes asking the patient to walk.
Thank you.
With the patient on a couch and their feet overhanging the end of it, look at the feet, comparing for symmetry. In the forefoot, look for nail changes and skin rashes. Look for the alignment of the toes and any evidence of hallux valgus of the big toe. Look for clawing of the toes, joint swelling and callus formation. Look at the underside or plantar surface for callus formation. Look at the patient's shoes for asymmetrical wearing of the sole, the presence of insoles or other signs of poor fit. Assess the temperature of the ankle and forefoot and check for the presence of a peripheral pulse.
Just going to squeeze across your toes. Tell me if it's sore.
Gently squeeze across the metatarsal phalangeal joints while watching the patient's face. The tarsal joints, ankle joint line and subtalar joints should all be palpated for tenderness. Range of movement in the foot and ankle includes inversion and eversion of the subtalar joint,
And can I ask you just to bring your big toe?
dorsiflexion and plantar flexion of the big toe, and dorsiflexion and plantar flexion at the ankle joint.
I'm just going to do that myself.
These should all be done both actively and passively. Mid-tarsal and subtalar movements can also be assessed passively. With the patient weight bearing, toe alignment and the foot arch should be checked.
Can you stand up on tiptoes?
A dropped arch in a normal subject resolves when standing on tiptoes.
Just turn away from me.
The hind foot should also be observed. Achilles tendon thickening or swelling may be seen. There should be normal alignment of the hind foot, and disease of the ankle or subtalar joint may lead to a varus or a valgus deformity. Gait should be assessed, looking for the normal cycle of heel strike and toe off.